Yes, sir. Videos are playing, sir. You can unshare your screen.
Yeah, sure.
Yes.
Sir, now the platform is open.
Give 2 minutes for the people to join and then
Okay.
we'll start. We may start now.
Yes, sir. So good morning and a warm welcome to all the dignitaries present here. Myself Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by Karnataka chapter of IACTA, Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation. And the topic of today's session is Infective Endocarditis Stepwise Assessment by TEE. So, now I would like to initiate today's session with a short video clip. So, just allow me a moment to play that.
morning and welcome to the Sunday breakfast session, which deals with echocardiography. And this is being conducted under the auspices of Indian Association of CT Anaesthesiology, that is Karnataka chapter of IACTA, Indian Association of Cardiothoracic Surgeons, Indian College of Anaesthesiologists, Global Heart Care Foundation, and International Society for Cardiac Ultrasound. I welcome you for this webinar. And today we have one of the eminent faculty dealing with infective endocarditis. And this will be moderated by Dr. Manoranjan Padhi. And the speaker is Jaffer. Both of them are accomplished cardiac anesthesiologists. And before I hand over to Dr. Manoranjan Padhi, I would like to request you to post your questions, comments on the chat box. We will address it at the end of the talk. With this, I request Dr. Manoranjan Padhi to take over.
Good morning, sir. Thank you so much for allowing me for this session. I should not delay the session. It is an interesting topic. So I welcome Dr. Mohammad Jaffer. He is a consultant cardiothoracic and vascular anesthesiologist from Narobi Hospital, Bangalore. So we should hand over to the Dr. Jaffer to start the session. Dr. Jaffer, please start the session.
Thank you, sir. Good morning, all. Dr. Murli sir and Manoranjan sir. So I'll begin my talk now. I'll share my screen. Is my screen visible?
Yeah, we can see it. We can see it.
Yeah, okay. So good morning, all. So I'll be talking about infective endocarditis. I'll begin with some introduction about that, its pathology. We need to understand its pathogenesis because that will affect, that will influence our the way of echocardiography. So we need to understand the pathophysiology of infective endocarditis. Then slowly we will progress to how all it manifests, what all as an anesthesiologist, as a cardiologist, as a cardiac surgeons, we should look into it. Then we'll find out about its complications, management, and outcomes in brief. So there is no disclosure, there is no conflict of interest, and I don't get any sponsorship for presenting this topic. So to start with, the infective endocarditis, which is a predominantly bacterial infection of the native or a prosthetic heart valve and the endocardial surface, it is very rare, affecting only 3 to 15 patients out of lakh patients. So, but the mortality is very high, like 20% in-house mortality and about 30% within a year. Before considering the etiology, what we all should understand is for an infective endocarditis to happen, there should be a vulnerable heart and there should be a portal of entry for the microorganisms into the body. So these two things has to be kept into mind. So the vulnerable heart means it can be either a rheumatic heart disease or a congenital heart disease with communicating lesions, shunt lesions, or if the patient is already a prosthetic valve in place or a catheter in place, who has undergone TAVI, TAVR. So all these patients, their heart is put into a vulnerable condition for the microorganism to grow there. So other non-cardiac conditions like patients who are injecting the drugs, who are having immunosuppression, dental or surgical procedures, hemodialysis, all these patients are notorious to develop infective endocarditis. So why I'm specifically telling about this, all this condition is because the infective endocarditis is a very, very rare situation, and you should have a very high clinical suspicion to diagnose that, because it goes unnoticed and we might find the patient in cardiac shock or pulmonary edema later. So starting with the pathophysiology, as you all know, initially it is the bacteremia, then the addition of the bacteria and the vulnerable endocardium, or the valve surface, then it proliferates, then it disseminates. So I'll come back to the slide once we start the complication so that we can understand it better. So it is a diagnostic challenge, as I have already told you. It usually presents with fever, new onset cardiac murmur, or a congestive heart failure. And the patient may present primarily with the embolic phenomenon or the conduction abnormalities. So how to proceed with the diagnosis? You need a high index of suspicion and a low threshold for the echocardiography to diagnose the infective endocarditis. Okay, so now the initial clinical assessment has to start with, like I told you, there should be vulnerable endocardium. So evaluate for the cardiac and the non-cardiac risk factors for the infective endocarditis. Then find the supportive clinical context for that patient. Then do the physical examination, including the portal of entry. So we all know that we use modified Duke's criteria for diagnosis of infective endocarditis. So in that, the imaging takes a bigger note of major criteria. So one criteria is the microbiological criteria where blood cultures are taken place. The other major criteria is the imaging. So in the imaging, if you are finding any material that is of no anatomical relevance and it is found near the valve or the perivalvular area or on the prosthetic material without any anatomical explanation, then that points the finger towards the infective endocarditis. And next comes the question whether transthoracic echo is best or transesophageal echo is best. We'll come to it one by one. So transthoracic echo, because it is available immediately, so it is the first line of investigation for all suspicious infective endocarditis, and that has to be performed immediately without any delay. Then transesophageal echocardiography adds to the sensitivity as well as the specificity compared to transthoracic echo. So based on AHA and European Society guidelines, transthoracic echo is the first line diagnostic modality for all infective endocarditis. So what does an echo tell you? So echo tells you about the predisposing heart condition, why the infective endocarditis has occurred. Then it helps you to establish the diagnosis, definitive diagnosis of infective endocarditis. Then it helps to identify whether there is any local complication inside the heart. Then it allows you to determine the prognosis, then assess the hemodynamic consequences, then for the serial evaluation and follow-up. So as an anesthesiologist or a cardiologist, so what all situations you will be encountering the patients to do an echo. So either you will be directly seeing the patients on the table of the operation theater, you will be putting a transesophageal echo. You don't know what to, I mean, you might be knowing it is a case of infective endocarditis, but you don't know what is the extent of the disease. So we'll slowly see what all to be seen in a case of infective endocarditis, how to report the echo, and what all to convey to the surgeon. That is what is most important for a practicing cardiac anesthesiologist. So in a cardiologist point of view, that they may have a clinical suspicion of infective endocarditis. They may start slowly evaluating the patient's heart one by one. So we need to know whether it is actually an infective endocarditis or it is something else. So for that, so we'll go into that. So transthoracic echo is the first line of diagnostic modality. So if your transthoracic echo is inconclusive, or if it is negative, but your infective endocarditis suspicion is always remaining high, or even if it is a positive TTE, your transesophageal echo has to be done. So in a simple term, transesophageal should always follow a transthoracic echo. Simple. Okay, and everything is a class 1 indication. Even if you don't find any vegetation or any suspicion or any confirmatory findings of infective endocarditis, but still the patient is having the symptoms, you can always repeat a echo after 5 to 7 days. So what are all the hallmarks of infective endocarditis? So as per European guidelines, they say the first hallmark to tell infective endocarditis is a vegetation, then is the development of abscess, then the local complications like development of fistula and the pseudoaneurysm. Other echocardiographic findings which may suggest it can be an endocarditis is the new onset of valve regurgitation or a new valve perforation, valve aneurysm, or a non-specific valvular thickening. So all these are some of the evidences that points the fingers toward the infective endocarditis. we'll start with vegetation. So in the first loop on my left hand side, you can see there is a vegetation attached to the septum, and it has created a shunt between the left. It is a left to right shunt, and in the right side in this loop, you can find the vegetation attached to the tricuspid valve leaflet. So how to how to define a vegetation? So vegetation is any oscillating intracardiac mass on a valve or any supporting structure which is in the path of a regurgitant jet or on an implanted material. So each word is very important. So it is an oscillating intracardiac mass. So it will be, most often it is an oscillating mass which is attached to a supporting structure or a valve or or on the path of a regurgitant jets. So each word is an important. So in the absence of an alternative anatomical explanation, so that is called as a vegetation. In this loop, we can see vegetation that is attached to the mitral valve and causing a ruptured chordae. So where all should we look for the vegetation? So you need to understand that in the case of infective endocarditis, vegetation usually occurs at the low pressure point. Okay, so if the vegetation is happening in the tricuspid leaflet, it will always be on the RA side of the tricuspid valve, not on the RV side. Similarly, for the mitral valve, it will be on the LA side. For the aortic valve, it will be in the left ventricular side. And in the first loop where we saw the VSD shunt, where the infective endocarditis is there, it is towards the RV. Okay, so it is the mass which is located at the low pressure zone or at the path of the regurgitant jet. Like if there is severe TR, the regurgitation happens into the RA, and we can find the vegetation inside the RA or on the RA side of the tricuspid valve. I have already told you the sensitivity and specificity for picking up a vegetation is very high for the transesophageal echo, except in certain circumstances like the right-sided vegetation, the transthoracic echo takes upper hand. How to differentiate between a vegetation and some other mass? So a vegetation, which is most often because of infective endocarditis, it oscillates independent of the valve motion. Unlike in other situation where the valve is thickened, it always moves with the valve. Then the local complications like abscess, fistula, pseudoaneurysm, prosthetic valve leak, or the dehiscence happens with the infective endocarditis and not with the other masses. And I have already told you the vegetation happens with the upstream to the valve in case of infective endocarditis. And then most often the infective endocarditis vegetation looks more amorphous and lobulated, unlike a stringy or hair-like appearance in the other masses. So when all can you get false negative echo? So you can miss the vegetations, or you cannot find any vegetations whenever the patient is on antibiotics, or if the patient has recent embolization. So the mass might have already migrated, or if there is a very small vegetations of less than 3 millimeters, then you may not find the vegetation inside the heart. Or if the vegetations are atypically located, then I have told you already. Or if the patient is having a prosthetic heart valve, which may mask the underlying vegetations. So in these conditions, you may miss the vegetations. So that is why it is always recommended to repeat the echo after 5 to 7 days so that you can find the vegetation. So next, coming on to, we need to know the differential diagnosis of the vegetation. So we cannot call all the structures, anti-anatomical structures as vegetations. So we need to identify what it is. Okay, so most of the time you can find thrombi, the naturally occurring Lambel's excrescence, cusp prolapse, fibroelastoma, or fibrosis of the CIEDs, that is implanted electrical leads inside the heart, that can get fibrosed and mimic like a vegetations. All right. So now we'll see one by one. In this loop, you can find a freely mobile oscillating thrombus inside the right atrium. So if it is not holding any true anatomical evidence, then it should be called as a if it is like if the patient is already having a triple lumen or central line placed in the SVC. So then it may be a dislodged part of or a broken part of that. Or if the patient is, so you should always compare with the clinical context in that patient. Next, moving on to the eustachian valve, which is the valve located between the IVC and RA junction. That can show you like a vegetation. Then the Chiari network that also mimic like a vegetations. Coming to the left atrium, so the normally occurring pectinate muscle inside the left atrial appendage can mimic like a small vegetation there, or the Q-tip sign, that is the Coumadin ridge between the left atrial appendage and the draining of the left upper pulmonary vein. You can misdiagnose it as a thrombus or a vegetation. Or after coming off bypass, and if the surgeon has put a LV vent, and while taking out the vent, and if your LA is not full with the volume, your left atrial appendage can get inversion into the LA, and it may mimic like a mass or a thrombus post-operatively. So all this. Next, moving on to the pericardial sinuses, oblique and transverse pericardial sinuses, they may become edematous post coming off, after coming off, and you can misdiagnose that as an abscess or like an infected cavity. Then the moderator band on the right side, if it is occurring on the left side, we call it as a left ventricular false tendon. So this can also mimic like a thrombus. Okay. So the one last thing, that is the bifid papillary muscle or the abnormal papillary muscle attachment. When you see that in the transgastric short axis view, you can misdiagnose that as a thrombus. Then the lambal excrescence that is occurring towards the aortic side of the aortic valve cusp. So that can be mimicked as mimic like a thrombus or fibroelastoma and so on. So all these are the differential diagnosis of infective endocarditis vegetation. So just with the presence of a mass inside the heart that is oscillating, you cannot diagnose that as a vegetation. We should always have a clinical context. We should always have a microorganism portal of entry. We should always have a clinical evidences supporting the infective endocarditis so that you can diagnose that. Next, moving on to the next hallmark, that is the abscess. Okay, so how does an abscess cavity? Okay, so the abscess usually occurs in the periannular area. Which is filled with pus or the necrotic material. Usually it occurs as an echolucent area. Sometimes the long-standing abscess can become hardened and it become an echo-dense area. Then by definition, an abscess will not have a communication with the major heart chambers or the heart vessels. So it will not be pulsating. So that is what it simply means. So in this loop, you can see a abscess cavity around the aortic valve. So these are the echolucent area that is present around the aortic valve. So once the abscess has occurred, so what are all the sequential events that can happen? Whenever you find the abscess cavity pulsating, or if there is a flow communicating with the mainstream flow, then this qualifies to be called as a pseudo aneurysm. Okay, so the abscess is different. Abscess means there is no definite communication between the heart chamber. Whenever the abscess cavity starts pulsating, or there is a communicating flow with the mainstream flow, then you call it as a pseudo aneurysm. When this abscess cavity is in communication with the nearby heart chamber, it is called as a fistula. When the infective endocarditis progresses to affect the valve, so it can cause variable thing, like it can cause perforation of the valve, or can cause aneurysmal changes to the valve leaflets, causing the valve to get weak, perforate, or even rupture of the cords, causing severe regurgitation of the valves. All right. Whenever there is a prosthetic valve that is present in the heart, so it can damage the sutures that is taken away for the prosthetic valve. It can cause prosthetic valve dehiscence. So by definition, we call the dehiscence as more than 40% dislodgement of the annular ring from the receiving ring from the annulus. That is called as the dehiscence. So the third hallmark which we call for the infective endocarditis is the new onset paravalvular leak or new onset prosthetic valve dehiscence. okay, which can cause the rocking motion of the prosthetic valve. So in this loop, we can see the cavity, which is enlarging with each systole, and there is a communicating chamber. So this qualifies to be called as a pseudo aneurysm. So this is the infective endocarditis of the aortic valve, which is causing the severe restriction of the valve leaflet, causing aortic regurgitation. And in the right side of the loop, you can see severe valve aneurysm. This is another thing which is called as a valve perforation. So the infective endocarditis can, so the pathogenesis I told you. So initially it will be bacteremia, then the microorganism causes adhesion of the organism to the endocardial surface or the valve leaflets. But then it causes proliferation of the organism there, and finally it causes dissemination. So this is the proliferation phase and causes the local complication on the valve leaflet, causing perforation. Okay. Okay, next moving on to the prosthetic valve endocarditis. So you can see in this the topmost loop. So there is a vegetation sitting at the 3 o'clock position, and in the lowermost loop you can see the rocking motion of the prosthetic valve. Okay, and it is causing severe paravalvular leak. All right. So this is the intraoperative picture where all the switches have, most of the switches have been given way, causing the prosthetic valve leak. Okay. So this is the post-op image of this patient taken after the removal of the prosthetic valve, and the new prosthetic valve has been put. Now there is no prosthetic valve leak. Now, after the local complication has been addressed, then you have to know what are all the predictors of embolism in an infective endocarditis. So as a general rule, for the left-sided infective endocarditis, a length of more than 10 to 15 mm, or on the right side, it is more than 20 mm, has a high chances of embolization. Or if the patient is on antibiotics, or if there is a recent increase or decrease in the size of the vegetation, then the vegetation located on the anterior mitral leaflet of the mitral valve, then they have a very high chances of getting it embolized. The other factors associated with the risk of embolism is like the type of organism, that is Staph aureus, Staph bovis or Candida, fungal infective endocarditis. The patient has already a history of previous infective endocarditis, or if it is multivalvular, then they have high chances of embolism. How are you going to report the echo? So first, starting with the vegetation, you need to know where the vegetations are located, how many in number, what is the maximum size of the vegetation, and the morphology, whether it is amorphous, lobulated, sessile, so all those. So you will report the morphology of the vegetation, number of the vegetation, location, and its size. So I have been consciously avoiding the 3D echo for the infective endocarditis. So I could find two very interesting articles about the role of 3D echo for infective endocarditis. So when you use the real-time 3D echo for assessment of the vegetation, so when the vegetation size of cutoff of more than 17 mm by 3D and more than 14 mm by 2D has a very high chances of infective endocarditis risk. Apart from that, like routinely where you use for all valvular regurgitation pathology or subvalvular to know the subvalvular pathogenesis, the real-time 3D echo is of much importance. So the other then coming back to the echo reporting. So first you will tell about the vegetation. Next you will address the local complication, whether there is an abscess, fistula, or a pseudoaneurysm. Then you will talk whenever there is a prosthetic valve, you will talk about the leak, whether the valve dysfunction, either it could be stenosis or regurgitation. Then you will assess the risk of embolism. Then finally, to complete the echo, you will address other valves, then the systolic and diastolic function of the heart. So this is how you have, it is better to report the echo, and to the surgeon, you will be reporting one by one all this. So after telling all this, we have to decide. So the echo is not only to diagnose, but also to plan for the surgery. Okay. So when to operate? So most of us, even me, till yesterday, we were thinking like after the completion of antibiotic course, we have to post the patient for surgery. No. So what American Heart Association tell, regardless of completion of full antibiotic therapy, the patient has to be taken for surgery, early surgery. So European Society has gone one step forward. They classified surgery into emergency, urgent, and elective surgery. Emergency surgery, they advise for if the patient is having impending cardiogenic shock or a patient is on pulmonary edema, then the surgery has to be emergently done. Urgent surgery, that is within the same hospital admission, irrespective of the course of the antibiotic, has to be done for if the patient is having severe infection or if the patient is having a risk of embolism. American Association of Thoracic Surgeon also tells that once the diagnosis of infective endocarditis is made, further treatment should not be delayed because of the risk of embolism. What are all the major indications for the patient to undergo surgery? There are three major indications. One is the heart failure, uncontrolled infection, or high risk of embolism. Okay, so as I have already told you, emergency surgery is indicated if the patient is on cardiogenic shock or on pulmonary edema. Other local complications like abscess, paravalvular leak, or pseudoaneurysm, or vegetation of more than 10 mm, the patient can have urgent surgery, that is in the same hospital sitting without before discharge. Or if the infective endocarditis is very virulent, the organism causing IE is very virulent or very aggressive, you can consider a non-urgent surgery. So surgical management for the right side. So right side, when do you post the patient for right side? So if the valve vegetation is more than 20 mm, or there is severe tricuspid vegetation that is not responding to inotrope or diuretic, or if it is caused by the fungal, then it has to be managed surgically. Next important question comes, if the mitral valve vegetation is there or tricuspid valve vegetation is there, should I post the patient for a repair or a replacement? So there is a general consensus that all infective endocarditis, the valve has to be replaced. No. So the systematic review, one on 2007 and the other on 2018, clearly says that if the mitral valve repair for infective endocarditis has got early and good long-term results, and the mortality is less compared to the replacement. And for sicker patients, and whenever you are having a combined procedure, only the replacement is advised. Okay, so even when the patient is going for the replacement repair, so the Carpenter's golden rule always apply. So what are the Carpenter's golden rule? You have to address the leaflet pathology. You have to ensure the good coaptation surface is obtained. Then you should strengthen the annulus with the ring. So why should we strengthen the annulus? One is to avoid the tension on the suture, and to bring the leaflet for the good coaptation surface. So mitral valve repair is offered to the patient with infective endocarditis. So the prerequisites are there should be a very limited amount of infection. Whenever it is involving only a single leaflet, preferably an anterior mitral leaflet, there is no local complications like abscess or a periannular extension. Only the valve leaflet is involved, then the repair can be safely done. So comparing the mechanical and non-mechanical valve, so it is the same general rule like old age patient, women of childbearing age. So the same principle apply for the mechanical versus the non-mechanical valve substitute. So this is one of the patient who is having the mitral valve vegetation that is over the anterior mitral leaflet, causing the rupture of the chordae, causing severe MR. So you can see the neocaudal resuspension in this patient, and good coaptation surface of 9 mm has been obtained, and in the post-op there is not much of a MR. So this is one mitral valve repair that is done for the infective endocarditis. All right. Okay. So what are the other anesthetic considerations like induction and maintenance? The same as you do for the other valvular pathology applies here also. When moving on to the recommendation to the anesthesiologist who is caring for the infective endocarditis. So the reason when guidelines says that we are a part of an endocarditis team, and we should involve ourselves in the during the preoperative risk assessment as well as in the decision making. Then the echocardiography has to be done immediately after the suspicion of the infective endocarditis is there. So immediately, then the intraoperative echo assessment for the infective endocarditis is also class 1 recommendation. Then for the follow-up also. Apart from that, an anesthesiologist should always focus upon other coagulation abnormalities, other organ damages during the heart surgery. So I don't want to finish my talk without addressing this. That is the prevention of infective endocarditis. So unlike the previous recommendation, so the recent recommendations guidelines have clearly told that the infective endocarditis is prophylaxis is recommended only for those patients who are having previous history of infective endocarditis or who is having an implanted prosthetic valves, TAVR, then the partially corrected or uncorrected cyanotic congenital heart disease, or if the patient who is fully corrected for the first 6 months, then who is the patients with VADS assist devices, then patients who is waiting for the heart transplant. Only for these patients, the infective endocarditis prophylaxis is recommended. So the drugs you can go through in the guidelines, what all to be given. So to summarize my presentation, the accurate diagnosis requires the integration of clinical suspicion, the microbiological information, and the echocardiographic data. The diagnosis can be facilitated by the integrated schema such as DICS criteria, and the imaging. I want to specifically tell that again that the imaging is one of the major criteria for the diagnosis of infective endocarditis. All patients with suspected infective endocarditis should undergo echo with the choice of modality tailored to the clinical situation. And you should have a very low threshold for doing a transesophageal echo. Then early surgical consultation is mandatory. Then who are the survivors of the infective endocarditis should undergo regular follow-up with the echocardiography. So these are all certain phases of the infective endocarditis. The initial critical phase, they will be treated with IV antibiotics, do the echo as early as possible, then remove the infective material as early as possible. Then patient moves on to the continuation phase. So before switching from the critical to the continuation phase, or before switching from the IV antibiotic to the oral antibiotic, echo is always indicated, and it is a class 1 indication. Following oral antibiotic therapy, the patient will be discharged and they will be on follow-up, and the regular follow-up has to be done with the echo for the size of the vegetation, for the regression of the vegetation, and to prognosticate them about the embolization risk. Some of my references are here. So that concludes my talk.
Thank you, Mr. Dr. Jaffer. It is good presentations with the all the details with the miniature form. I would say this is though it is a very rare disease, but it is a very aggressive. So the very aggressive manner. I will summarize it. It is located in the low pressure area, and it should be diagnosed with the Duke's criteria. So that it will be as you says, there's a LV side. Aortic valve will have a LV side. It is on the lesion will be in the LV side, and the mitral valve will be lesion on the LA side. And then the T is definitely T is the 90% sensitivity and specificity on diagnosing the endocarditis. Even TT it is the far better than the TT. And other way also you can go for the CT or cardiac MRI for diagnosis. Of course, there are false negative. So most common false negative as per the I know somewhere there's a fungal endocarditis is a very difficult to diagnose even in the TE. So we have to if patient is symptomatic having fever and all these things, So we should exclude is there any fungal endocarditis? So that is why I think 3D TE will be helpful for the small vegetations, and it is mostly on the margin of the wall. So fungal endocarditis should be excluded. Then other differential diagnosis, like you said, the thrombi and cause collapse. This thing has to be obviously has to be excluded. Then the other is this complication like embolization is there. So this nicely you have described that emergency surgery and urgent surgery European guidelines is nicely described. It's a very good presentation. I have one questions. How long we should continue the antibiotic for this and infective endocarditis after surgery?
So the antibiotics actually, what has been told us, it depends upon the surgery. If the valve has been replaced, prosthetic valve is there. So till the critical phase, we have to continue the IV antibiotics. After the critical phase is over, like after 14 days, then it will be converted into the oral antibiotics. So after the oral antibiotics of 1 week, then again the blood culture has to be sent. And once your tissue diagnosis is done, then this antibiotic phase can be safely discontinued. So initially it will start with the critical.
Yeah, that means minimum 3-week antibiotics should be covered and reassess the patient.
Definitely.
Okay, now sir Mulli sir, now sir you can take over, sir. And I think this meeting.
Yeah, thank you so much, Dr. Jaffer. Very well presented. All the important points have been covered. And you just look into the chat box if there's any questions. Comments from my side are that it's a very, as already said, though rare, it has a 20% hospital mortality. And we have to have a high index of suspicion and then do the imaging as and when needed, and then take on. I think there is one question on that. What is your take on coronary stent infection? Jaffer, do you want to answer that?
I think, is it a question or a comment? Coronary stent infection.
I think it is a comment, sir. It is a comment. It is a coronary stent infection being it's in the late also. That is what Dr. Ratan Gupta has given a comment.
Yeah, the patients will have symptoms of fever, chills, chest pain, angina after the procedure, and early recognition again is important, and antibiotics are indicated, and if necessary, it may be removed by surgical access in complex cases. Dr. Ratan, do you want to say anything? You can unmute yourself and say. Any other comments?
No, sir, no other comments or questions.
Good morning, sir. I'm Dr. Rachna Wadhwa from New Delhi, sir.
Yeah, please feel free.
Sir, we had a case of fungal anacarditis, and then it was so malignant that we could not even save the patient even after re-exploration. So what should we do in such scenarios? Means the antifungal course, regime, assessment, surgery, all those things.
So this fungal endocarditis with vegetations is common in patients who have immunosuppressive treatment. or as patients or subjects who use intravenous drugs. And here we have to be a little aggressive, and combination of medical and surgical intervention should improve the outcomes. Jaffer, do you want to say anything about fungal infections?
Yeah, fungal actually, yeah, it's a very aggressive treatment and it's more commonly
Yes.
virulent. And antifungal treatment and antibiotic treatment has to be very aggressive, more, I mean, compared to the bacterial infection. It and the duration.
So what are the recommended drugs and duration for that? I just wanted to know if there are any specific guidelines per se.
Yeah, the European guidelines of 2023, the antimicrobial prophylaxis for infective endocarditis, I think it is clearly given. You can go through that.
Okay,
Yes.
okay. Thank you. Okay.
There are two more comments also coming, sir. This is
Yeah.
Dr. Sunil. Dr.
Yes, if there's a vegetation without blood culture positivity, do you call it as infective endocarditis?
You can, if clinically patient is there, and if you think you can stamp as a infective endocarditis. That is there in the criteria.
I didn't get that. Can you please repeat it? What you said?
Sir, he says that having a vegetation without blood culture positive will be stamped as a infective endocarditis.
Yeah.
Yeah, that is basically those are, sir, previously having antibiotic, all these things, they will not have a blood. If you have a T finding, if you have vegetation, definitely we should stamp as a infective endocarditis. It is I think I will agree on this, his suggestions.
Yeah, yeah. Jaffer, do you want to comment on this? Dr. Jaffer, are you there?
The voice broke, sir. Can you repeat, sir?
So the question is, if there's a vegetation, but the cultures are negative, if you will you still label it as infective endocarditis?
No,
That's the question.
It can be healed vegetation also. Like the patient could have already taken an antibiotic course, and the vegetation might have healed, and we can find the vegetation there, but still the blood culture may be negative. So it has to be called as an infective endocarditis, but patient should be kept on follow for any further increase in the size of the vegetation or aggression of that. So they have to be kept on follow. It has to be qualified to be called as an infective endocarditis.
One more question is there. Course of antibiotics and duration changes and need to surveillance culture. Need for surveillance culture. Can you answer this question, please?
Yeah, like we have already told. So initially we start with the IV antibiotics, then proceed with the oral antibiotics, then do the repeat cultures and do the repeat echocardiography before switching from one modality. So based on that, if your still blood culture is positive, if it is always positive, so that is one of the indication for the surgery. So if your infection is still present, persistent infection is one of the indication for the surgery. So you eliminate the infective pathology from the heart, then you can repeat the culture after a week or two, then decide on the course of the antibiotics.
So another question about what type of antibiotics would you like to use? I think that's what it means. I'll just read it out for you. What group of antibiotics to consider?
Yeah, depending on the culture and sensitivity of the blood culture, the organism is growing, we decide on the antibiotics. So there is no clear-cut antibiotic like this has to be used. So we start with the broad spectrum antibiotics initially, then we tailor the
Yeah.
type of the antibiotic to the culture sensitivity it grows.
So I do agree with the Mr. Dr. Jaffer also because without we are practicing the evidence-based medicine. So without culture sensitivity, we should not start antibiotic empirically higher antibiotic. If culture sensitivity is not there, anything in growth is not there, we should start the basic and we repeat the culture, and according to the culture reports, we should switch over to antibiotics.
Yeah, true.
Right. And for high risk dental procedures, what antibiotic do you recommend?
So if the patient is penicillin sensitive, we can go for a penicillin group of antibiotics. If they are
Yeah.
resistant, then always we give a clindamycin 600 milligram for the prophylaxis. And even for the prophylaxis, there are various other regimens that is available. What sort of, it is based on individual hospital environment. So there is a clear-cut guideline on prophylactic antibiotics, what all to be given. So that can be.
Yeah. Any other comments or questions before we conclude?
No, sir.
Okay. Thank you so much, Dr. Jaffer and Dr. Manoranjan, for being with us today morning.
Thank you, sir.
For-
I've been honored to you allowed me. I've been honored, and I am always getting blessing from you. That is why I am here now. So
Thank you
so much.
so much. Thank you for saying that, and I would like to thank you for joining us, and also Dr. Jaffer for highlighting the echocardiographic aspects of infective endocarditis. And thank you so much, and we look forward to having you again. And before we conclude, Rupsa, do you have some announcements
Yes.
to be made?
Yes, sir.
Two
Yes, sir.
announcements and that in one video. This is the next year IACTA TE workshop will be held at Bangalore, Narayan Vidyalaya from 20th to 23rd August. Please join us. This is an international event. Next one.
Yes, sir. Please.
We conduct fellowship in critical care echocardiography under the auspices of IACTS and ICA, Global Heart Care Foundation, and in International Society for Cardiac Ultrasound. 2 batches have finished. Third batch is starting from 1st January 2025. Anyone interested, please contact us. Last date to apply is 31st December. Next one.
The next one is a video, so I'm playing the video.
Yeah. Next one is a video on Global University of Cardiac Sciences, which is under the auspices of Global Heart Care Foundation in Arizona. This university deals with cardiology, cardiac surgery, cardiac anesthesia, critical care, echocardiography, and perfusion. The aim of this university is to give important information by means of webinars and develop skilled professionals in all aspects of cardiac care. And in the subsequent days to come, we'll be running fellowship programs and PhD in cardiac sciences. These are the subjects which are included under this banner. Thank you so much for joining us and looking forward to seeing you again next Sunday. Thank you so much.
Thank you so much, sir. Thank you so much, everyone, for giving us the opportunity to host this session. So with this, we are ending today's session over here and looking forward to host you again. Thank you so much, everyone. Have a good day.
Have a great Sunday. Thank you.